frequently asked questions about obsessive compulsive disorder. How prevalent is OCD? The lifetime prevalence of OCD is 2.3%. The mean age of onset is 19.5 years, and it is rare for new cases of OCD to develop after the early 30s. The lifetime risk of developing OCD is higher in females, who typically develop the disorder in adolescence. How is OCD diagnosed? Diagnosis requires the presence of obsessions, compulsions, or both. Obsessions are recurrent and persistent thoughts, urges, or images that are experienced, at some time during the disturbance, as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. The individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. Compulsions are repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. The obsessions or compulsions are time-consuming or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The obsessive-compulsive symptoms are not attributable to the physiological effects of a substance or another medical condition. Is OCD considered an anxiety disorder? OCD is now recognized as a disorder distinct from anxiety. It is now grouped with several other disorders with common features, often referred to as obsessive-compulsive related disorders. What conditions may be misdiagnosed as OCD? These conditions are ADHD, anxiety disorder, autism spectrum disorder, depression, psychotic disorder and Tourette syndrome. When do we suspect someone has OCD? Physicians should consider the possibility of OCD in patients with general complaints of anxiety or depression. The use of a few simple screening questions can be helpful. Do you wash or clean a lot? Do you check things a lot? Is there any thought that keeps bothering you that you would like to get rid of but cannot? Do your daily activities take a long time to finish? Are you concerned about putting things in a special order, or are you very upset by mess? Do these problems trouble you? If a person answers yes to any of these questions and the symptom causes distress, a diagnostic interview should be administered. What is the natural history of OCD? OCD has a substantial effect on quality of life and level of functioning. It is often a chronic disorder and is likely to persist if not treated effectively. Significant improvement or remission is possible when aggressive treatment is applied early. Does OCD have other comorbidities? In their lifetime, 90% of patients with OCD meet criteria for at least one other psychiatric diagnosis. The most common comorbid diagnoses are anxiety disorders, particularly major depressive disorder, impulse control disorders, and substance use disorders. The risk of suicide in persons with OCD is high. As many as 63% of persons with OCD had experienced suicidal thoughts. How should OCD patients be managed? Once OCD is diagnosed, patients and family members should be educated about the chronic nature of OCD and the importance of self-management skills. Medical and behavior therapies can reduce the severity and frequency of obsessions and compulsions, and can induce remission in some patients. However, it may take weeks to months for these therapies to become effective. Patients should be assessed for suicide risk and presence of comorbidities throughout the course of their illness. Is psychological therapy alone effective in OCD? In many cases, psychological therapy alone is effective in treating OCD. Cognitive behavior therapy, specifically exposure and response prevention, is the most effective psychotherapy method for treating OCD. Patients are exposed to anxiety-provoking stimuli, and learn to not perform compulsive behaviors in response. Which pharmacotherapy should be started on OCD patients? Selective serotonin reuptake inhibitors or SSRIs are preferred for initial therapy. To achieve optimal response, patients with OCD require a higher dosage of an SSRI compared with other indications. The dosage should be increased over 4 to 6 weeks until the maximal dosage is achieved. It usually takes at least 4 to 6 weeks for patients to note any significant improvement in symptoms. If medical therapy is successful, it should be continued for at least 1 to 2 years, if not indefinitely. What if the patient does not respond to the initial trial of SSRI or behavioral therapy? If an adequate trial of SSRI or psychological therapy does not result in a satisfactory response, combined treatment is an option. If the patient prefers to continue with medical therapy alone, a trial of a different SSRI is warranted. Addition of an atypical antipsychotic is effective for some patients with inadequate response to SSRI therapy.
Audio Jungle. Audio Jungle.